Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is August 5th, 2025. This video is on a European Journal of Heart Failure article published recently titled Heart Failure Improvement, Remission and Recovery, a European Journal of Heart Failure expert consensus document. Most of the authors are from Europe. I do recognize Lynn Warner Stevenson. Any article which she's on is high quality in my opinion. Improvements in left ventricular ejection fraction occurs in about 20% of HFrEF patients. Heart failure, the improved ejection fraction lacks precision. This article emphasizes new terms and definitions: improvement, remission, and recovery. It emphasizes functional, structural, and biomarker normalization. New terminology: heart failure with improved ejection fraction when the left ventricular ejection fraction is greater than or equal to 10% increase from baseline, which is below 40% to greater than 40%. REM heart failure is where the left ventricular ejection fraction is greater than or equal to 50%. Minimal symptoms, stable left ventricle, NT-proBNP normal for greater than 12 months. Recovered heart failure, full normalization in structure and function, NYHA class 1, NT-proBNP less than 125 picograms per ml for 24 months. Different relapse risks, terms are not interchangeable. Frequency and predictors. Recovery is rare, remission more common. Predictors: non-ischemic etiology, peripartum cardiomyopathy, chemotherapy withdrawal, inherited cardiomyopathies due to truncated variants of the titin gene, and young age. Remission is not cure. Relapse occurs in around 10% every year. Predictors: increase in NT-proBNP, decreased left ventricular ejection fraction, increased LV volumes and fibrosis, and LV strain. Monitoring: LVEF insufficient alone. Use GLS, LA strain, fibrosis, MRI, NT-proBNP. Serial tracking rather than just one-time values. Management implications: GDMT continuation is essential. In TREAD heart failure, there was 44% relapse after withdrawal. Loop diuretics may be tapered cautiously. CRT deactivation is discouraged. ICD decisions are individualized. Beta blocker withdrawal is being studied in the Bonfire trial. Conclusion: improvement, remission, and recovery reflect a spectrum. This article should help stratify relapse risk and personalized care. There is a need for validated, standardized criteria. So frequently asked questions: what is heart failure with improved EF? LVF improves equal to or greater than 10% from a baseline less than or equal to 40% to greater than 40%. REM heart failure versus REC heart failure. REM heart failure is stable, not fully normalized. REC heart failure, recovered heart failure, full normalization of function, structure, biomarkers. Can the meds be stopped? Not advised. Relapse common unless in trial or with adverse effects. How common is a relapse? It's pretty common. It's around 10% annually. Who recovers? Non-ischemic heart failure, peripartum cardiomyopathy, truncated variants of the titin gene, younger patients. Monitoring tools: LVEF, GLS, LA strain, NT-proBNP, cardiac MRI. ICD, CRT deactivation. CRT should stay on. ICD should be individualized. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.